Ramya, that is not important for you now. That is
important for me for my day.
నా క్లాస్ తర్వాత ఇప్పుడు అది ఉంచి నాకు ఈ డోర్ తెరవడం వల్ల నాకు అంత డిస్టర్బెన్స్ వస్తుంది లోపలికి.
దానికి సొల్యూషన్ ఈ డోర్ నేను స్టాప్ చేయడం నాకు ఇంపార్టెంట్, నాకు చాలా ఇంపార్టెంట్. మీకు ఇంకేమైనా డిస్టర్బెన్స్ అయితే అంటే చెప్పి నేను అది క్లియర్ చేసేస్తాను.
కొంచెం నోరు మూసుకోండి.
ఓకే.
Yes. So good evening, everyone. So please let me know, am I audible to everyone? Yes. So I welcome you all to this particular session for today. Very good. Now let me start the today's session of both clinical and as well as the image-based questions being combined. I hope until yesterday, like we were discussing, like both clinical and as well as the image-based questions. Now let me try to continue with the same type of sessions with images and as well as a clinical base. Okay, so you see this question. We have a 17-year-old boy right. So we have a 17-year-old boy with these lesions, complaints of abdominal pain and the back pain. All of the following are true of this disease, except the options are from 10 to 20% of the patients have arthritis that mirrors the disease activity. Second option, it may be associated with ankylosing spondylitis. Third option, renal oxalate stones occur in 5 to 10% of the patients. Fourth option, smoking has been associated with the preventive effect. Fifth option, pathological findings are marked by segmental bowel inflammation and skip lesions. Yes. So who will be the first person to tell me the answer? Right. So we got one particular answer from okay. So very good, Shabnam Khan. So Shabnam Khan has answered it correctly. So the answer here is smoking has been associated with the preventive effect. This is the false statement. See, the question asked is except. That means which is the false statement is the question which is being asked. The false statement here is smoking has been associated with the preventive effect is a false statement here. Okay. So Shabnam Khan, can you tell me what is the diagnosis of this patient? What is the diagnosis in this case? Yes. So diagnosis in this particular patient is very good, Shabnam Khan, excellent. So diagnosis in this patient is the Crohn's disease. Right, it is the presence of the Crohn's disease. Now, why is it Crohn's disease? Why is it Crohn's disease? Let me take up the discussion of the Crohn's disease. Now, in case of the Crohn's disease, lesions, they are present from mouth up to anus. Right, in case of the Crohn's disease, the lesions, they are present from mouth to anus. And the other important feature of the Crohn's disease is that they will have the skip lesions, right? And these pathological findings are marked by segmental bowel inflammation and the skip lesions. So presence of segmental bowel inflammation, presence of the skip lesions, and the lesions which are present from mouth to anus, all these, they are suggestive of the Crohn's disease. Now, apart from that, what are the other associated findings? The associated findings in Crohn's disease, they include intestinal fistulas, strictures, and the perianal disease, right? And as well as the perianal disease. And in Crohn's disease, remember, almost just 1 second. Right. So the other important point in the Crohn's disease is almost like 10 to 20% of the patients of arthritis that mirrors the disease activity. That mirrors the disease activity. And this particular Crohn's disease, let me tell you, it is also associated with the ankylosing spondylitis. Now, can anyone tell me what is the HLA association in ankylosing spondylitis? Any one of you, please. what is the HLA association in case of the ankylosing spondylitis? Right. So the HLA association, it is HLA B27, right? HLA B27. Now, yes, that is what, yes, Shabnam Khan, that is what is asked here. That is what is asked here. What is the false statement is asked here. So smoking has been associated with a preventive effect. That is a false statement in case of the Crohn's disease. See, smoking has been associated with a preventive effect in case of ulcerative colitis. Right, in case of the ulcerative colitis, not in case of the Crohn's disease. Okay, and the other point is, in these patients with the Crohn's disease, they will also have renal oxalate stones. These renal oxalate stones, they occur in almost 5 to 10% of patients. And why is this particular renal oxalate stones in these individuals? These renal oxalate stones occur in 5 to 10% of patients, and they are due to malabsorption of the calcium. Right? And they are due to malabsorption of the calcium in these individuals. Right? Whereas you take ulcerative colitis, smoking appears to have some preventive effect in ulcerative colitis. Whereas in Crohn's disease, remember, smoking is a risk factor for the development of the Crohn's disease. Right? Smoking, it is a risk factor for the development of the Crohn's disease. Okay, so that is one of the very important point. Right? Now, please tell me, how do you treat these patients with the Crohn's disease? Can anyone tell me how do you treat this Crohn's disease? Yes, please tell me the treatment of the Crohn's disease. So the treatment, remember, it all depends upon the site and as well as severity. Yes, Aniket Raj, ankylosing spondylitis, yes, it is also associated with ulcerative colitis also. And it is also associated with the Crohn's disease as well. Yes, Aniket Raj, whatever you are saying is correct. But remember, it is also associated with the Crohn's disease, right? So the treatment, it all completely depends upon the site and as well as the severity. It all depends upon the site and as well as the severity. What all options we have, like sulfasalazine. Then everyone is telling about the steroids. Very good. The steroids. Then 6-mercaptopurine, then metronidazole. We have a monoclonal antibody, that is infliximab. So these are all the options of the treatment, like what we have for the Crohn's disease. These are all the options of the treatment what we have for the Crohn's disease. You see, Mr. Gayaz Mohammed, what is given, the option you see properly, don't be in a hurry. Smoking has been associated with a preventive effect. That is what is given in your options. So does the smoking has a preventive effect in Crohn's disease? No. Smoking is a risk factor for the Crohn's disease. Right? The point given is preventive effect. In Crohn's disease, smoking doesn't have the preventive effect. In ulcerative colitis, the smoking has been associated with the preventive effect. Right? Yes, Gayaz Mohammed, is it clear for you now? Okay. So this particular question, it is on the inflammatory bowel disease, right? And within the inflammatory bowel disease, which particular subtype? It is the Crohn's disease. Okay. Now we will move on to the next important image and as well as the clinical based question together. Now, can anyone tell me what are the other disorders which are associated with the HLA-B27? One is ankylosing spondylitis, and the other one is inflammatory bowel disease. And what are the other diseases which are associated with the HLA-B27? Can anyone answer me? Right. So the other diseases which are associated with the HLA-B27 include Reiter's or reactive arthritis, right? Reiter's or reactive arthritis, and the other one is very good, very good. Everyone is answering now. That is even psoriasis. Right, even psoriasis. Okay, so psoriasis, ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis. So all these are the diseases which are associated with the HLA-B27, right? HLA-B27. Okay. Now, in case of psoriatic arthritis, which joints are commonly involved? Can anyone answer this? In psoriatic arthritis, which joints are commonly involved? Can anyone answer this question? Which joints are commonly involved in psoriatic arthritis? So remember, in case of psoriatic arthritis, the joints which are commonly involved is distal interphalangeal joints, DIP. Distal interphalangeal joints are the one which are commonly involved in case of psoriatic arthritis. So very good, Chandia. Right. Now we will move on to the next question. Okay. So if you see this question, after the treatment for urethritis, right? After the treatment for urethritis, an 18-year-old man presented with skin condition, which is shown here, right? This is the skin condition. Other appropriate uses for the agent implicated in this case include all of the following except, now you see the options. A 45-year-old woman with pelvic inflammatory disease. Second option, a 62-year-old man with early stage Lyme disease. Third option, a 29-year-old pregnant woman with Vibrio cholera. Fourth option, a 55-year-old woman with Borrelia recurrentis. Fifth option, a 30-year-old man with community acquired pneumonia. Right, very good, Shabnam Khan. So Shabnam Khan, can you tell me what is the antibiotic used? Can you tell me what is the antibiotic used here? For the urethritis, what is the antibiotic used and what is the diagnosis here? What is the diagnosis of this particular case? So Shabnam Khan answered, Monica Moni answered. Please tell me what is the antibiotic used and what is the diagnosis in this case? So remember the point here that no. Redman syndrome, yes, Adarsh Soni. Redman syndrome is seen in patients with taking vancomycin, right? No, it is not Reiter syndrome. Yes, Shabnam Khan, Monica, Sai Taruni, you have answered correctly. But tell me what is that antibiotic used? No. Right. So let me tell you now. See, this particular patient having urethritis, what has been given to him is the tetracycline. So what is the diagnosis of that patient? It is tetracycline induced phototoxic dermatitis. Tetracycline induced phototoxic dermatitis. Very good. So Gopalakrishnan has answered it. So what is the tetracycline being used? The tetracycline which is being used is doxycycline or minocycline. Now, what is that particular phototoxic dermatitis manifestations? These phototoxic dermatitis manifestations include rash, urticaria, photosensitivity, angioedema, and then dyspepsia. So these are the manifestations of the phototoxic dermatitis. These are the manifestations of the phototoxic dermatitis. Now, this particular doxycycline can be used in other conditions, like you see, a 45-year-old man with pelvic inflammatory disease, yes, we can use doxycycline or we can use minocycline in this particular patient. Now, you take the other clinical scenario, that is a 62-year male with early stage Lyme disease. So if you take the organism causing this particular Lyme disease, the organism causing Lyme disease, it is Borrelia burgdorferi. So Borrelia burgdorferi, what is the drug of choice? Definitely the drug of choice will be your doxycycline. But you take the third option. In the third option, that is option C, what is given? Pregnant women. So in pregnant women, please tell me, can you give tetracyclines? Can you give tetracyclines in a pregnant woman? So remember, in a pregnant woman, the tetracyclines, they are avoided. Right? In pregnant women, the tetracyclines, they are avoided. Why? Because this particular tetracyclines, they have teratogenicity. What is the teratogenicity? Number one, retardation of the bone growth. Right? There is retardation of the bone growth. And there will be also discoloration of the teeth. Right? There will be discoloration of the teeth in the newborn. Right? In the newborn. So that is the reason why, remember, the tetracycline, it is contraindicated in pregnant women. So the question asked is what? Other appropriate use for the agent implicated in this case include all of the following except. So what will be the answer now? The answer will be C. The answer will be C. And you take even your like fourth option, Borrelia recurrentis. So in case of Borrelia, what is the drug of choice? Again, it is your tetracycline, doxycycline. Okay, now you take the last one, that is the community acquired pneumonia, 30-year-old man, community acquired pneumonia. You can give doxycycline. You can give doxycycline, that is tetracyclines in these individuals. Okay. So, but the third option, that is in the pregnant women, you cannot give this particular doxycycline. So that is a complete contraindication. That's a complete contraindication. Now, with this tetracycline, can anyone tell me what will be the CNS adverse effect? Anyone? What is the CNS adverse effect with outdated tetracyclines? What is the CNS adverse effects with outdated tetracycline? Anyone? Yes, please answer that. So if you take the CNS adverse effects with outdated tetracycline, remember, no, it is not insomnia. And the similar adverse effects, even you will get with retinoids. That is nothing but pseudotumor cerebri. Right? That is nothing but pseudotumor cerebri. So pseudotumor cerebri, it is one of the adverse effects with the consumption of outdated tetracycline. So please remember that point. Okay, right. Now we will move on to the next important clinical and image based question. Right. So this is another very interesting question, and let me see how many of you can answer this. We have a 34-year-old male smoker. He reports having wrist pain and lower extremity digital ulcers for 2 months. He also reports a 1-year history of claudication, right? Claudication pain is there. Which one of the following is the best means of preventing the amputation? right? Which one of the following is the best means of preventing the amputation? You see the question clearly. Preventing. The question asked is preventing. The options are smoking cessation, calcium channel blockers, peripheral arterial bypass, pentoxifillin, warfarin anticoagulation. What is the answer in this patient? So first of all, please tell me what is the diagnosis? Now diagnosis bolna, pehle diagnosis bolna. Whoever is answering, yes, Srihari Aditya, you have answered it correctly, but tell me what is the diagnosis? Monica, diagnosis please. Diagnosis bolna pehle, diagnosis. So diagnosis in this individual is no, it is not gangrene. It is not gangrene, man. It is not gangrene. Right? It is nothing but your Buerger's disease. So Buerger's disease, which is also called thromboangiitis obliterans, which is nothing but it is a medium vessel vasculitis. Right? It is a medium vessel vasculitis. Right? Now, for this particular Buerger's disease, remember, the very important risk factor for the progression of the disease is smoking. Right? The very important risk factor for the progression of the disease in these individuals is smoking. Right? So these individuals, they have to stop smoking. Right? They have to stop smoking. So once they stop smoking, then that is a very important preventive effect. The question asked is preventive. Which one of the following is the best means of preventive amputation? So ask the individual to stop smoking because he's a smoker. And smoking is a very important risk factor for the development of TAO, that is thromboangiitis obliterans. This is a very important risk factor for development of Buerger's disease or thromboangiitis obliterans. Okay, so you should advise the patient to stop smoking. And this thromboangiitis obliterans, remember, it is very common in smokers. And these thromboangiitis obliterans patients, almost like 40% of persistent smokers, 40% of these persistent smokers, they will face amputation. Right, 40% of the persistent smokers, they will face the amputation. Okay, so that is about your Buerger's disease. Right? Does anyone have any doubt in this question? Right, see, apart from this, we have one more Buerger's. Now, let me see how many will answer this. We have another Buerger's disease. Can anyone tell me what is this Buerger's disease? Yes, please answer me. What is this Buerger's disease? See, this is your BUER. This is your BUER. What is BERGERS disease? Right, who will be the first person to answer this question to me? Very good, Chandia. Excellent. So this is your IgA nephropathy. This is your IgA nephropathy. Okay, where the individual will have the features similar to that of nephritic syndrome. Where the individual will have the features similar to that of the nephritic syndrome. That is what is called as Buerger's. So always remember, you should never get confused. Thromboangiitis obliterans, that is BU. Whereas Buerger's disease, IgA nephropathy, BE. That's all. Right? That's all. Okay. Next. Now, after having discussed about this thromboangiitis obliterans, so everyone is aware that thromboangiitis obliterans, it is a medium vessel vasculitis. Can anyone tell me what are the other examples of medium vessel vasculitis? Thromboangiitis obliterans is a medium vessel vasculitis. What are the other examples of this medium vessel vasculitis? Anyone? So the other example for this particular medium vessel vasculitis include Kawasaki disease. Kawasaki disease is also a medium vessel vasculitis. The other one is very good. Chandiya and Vishnu has answered it. Excellent. Right? Kawasaki disease and as well as the polyarthritis nodosa. Polyarthritis nodosa. Very good. Arya Rajesh, Monica, Gopalakrishnan. Excellent. Super. Vishnu. So these are the other examples of your medium vessel vasculitis. Okay? Now among these three conditions, where do you have strawberry tongue? Where do you have strawberry tongue among these three conditions? Anyone? Strawberry tongue is seen in which of the following conditions causing medium vessel vasculitis? So, excellent, superb. So, strawberry tongue, it is seen in patients with the Kawasaki disease. It is seen in patients with the Kawasaki disease. And Kawasaki disease is the one which is commonly seen in children. Right? Which is commonly seen in children. Okay? Right. Now, we'll move on to the next question. Yes. Okay. So you see this question here. We have a 78-year-old male smoker. 78-year-old male smoker presents with profound weight loss and a chronic cough. Right? And chronic cough. During World War II, he was employed at the local Navy shipyard. Right? He was employed in the local Navy shipyard. Which of the following is the most common pulmonary finding in this disorder? Chest X-ray is given. Options are also given to you. Pulmonary embolism, pleural plaques, pleural effusion, pulmonary fibrosis, malignant mesothelioma. Please answer this. No, I did not get the correct answer. Yeah. So whoever has answered, right. So whoever has answered C, whoever has answered C, that is pleural plaques, that is a correct statement, right? Whoever has answered C, that is a correct answer, right? Now, let me explain you first of all. Can anyone tell me what is the diagnosis in this case? Yes, can anyone tell me what is the diagnosis in this patient? So, diagnosis in this clinical scenario is, diagnosis bolna. I'm waiting for diagnosis. So, diagnosis in this clinical scenario is asbestosis. Diagnosis in this patient is asbestosis. Now, sir, why are you telling asbestosis? Why are you telling asbestosis? Why? Because he was employed at the local Navy shipyard, right? Local Navy shipyard. That is, asbestosis is one of the clinical condition which has a risk factor in those individuals who work near the shipyards, where there is excessive exposure to the asbestos. Now, whenever there is exposure to the asbestos fibers, the individual will develop pleural effusion. The individual will develop pleural plaques. The individual can also develop malignant mesothelioma. All these three are seen in asbestosis. Pleural effusion can be seen. Pleural plaques can be seen. Malignant mesothelioma also can be seen. But the answer is the pleural plaques. Why? You see this. This is a plaque. This is a pleural plaque. Now you can see here also, this is a pleural plaque. Okay, now, yes, you can have, yes, Srihari Aditya, asbestos, it can be related to your weight loss. It can be related to your weight loss. So now asbestos exposure can have all these three. Pleural effusion can be there, pleural plaques can be there, and malignant mesothelioma also can be there. But which is most common? Most common is pleural plaques. Most common is pleural plaques. Okay. Now, what is the question asked? Most common pulmonary finding is asked. Right? What is the question asked? The question asked is the most common pulmonary finding. So what is the most common pulmonary finding? The pleural plaque. Okay. Next, the other point is you take the asbestos, which lobe is commonly affected? Remember, in case of asbestosis, the lower lobe abnormalities are very common. Right? Lower lobe abnormality is predominantly seen in patients with the asbestosis. And see, he is like 78-year-old man, right? And when will the manifestations of asbestosis will develop? The clinical manifestations of asbestosis will develop. It may occur 15 to 40 years after the initial exposure. Right? It can appear 15 to 40 years after the initial exposure. So 15 to 40 years after the initial exposure, the individual can develop the clinical manifestations of the asbestosis. Right? Now, if you take this particular asbestos fibers, if you take this asbestos fibers, there are two classes of asbestos fibers. Now, can anyone tell me what are those two classes of asbestos fibers? What are the two classes of the asbestos fibers? Anyone? What are the two classes of the asbestos fibers? Right. So let me tell you that. So the two classes of the asbestos fibers include, number one, serpentine form, and the other one is the amphiboly. Serpentine form, and the other one is the amphiboly. So you see that. So serpentine form, it is curly, right? And the other one is the amphiboly. So amphiboly, it is straight and rod-like. This is straight and as well as rod-like. So these are the two classes of, excellent. So these are the two classes of the asbestos fibers. One is serpentine and the other one is the amphiboly. Okay. So now in the serpentine type, the subtype like what we have is a chrysolite. Right, the subtype what we have is a chrysolite. So chrysotile, not chrysolite, chrysotile. So chrysotile, it is the subtype, and this will account for nearly 95% cases of the asbestosis. Right, the chrysotile, it is the subtype of your serpentine type that constitutes nearly 95% cases of your asbestosis. Okay. Now, this asbestosis, actually what it will do, it will also cause the interstitial lung disease. It refers to diffuse interstitial lung disease. So in the sense, it will also cause pulmonary fibrosis. So once there is pulmonary fibrosis, the individual may land up in hypoxia, and this hypoxia will cause pulmonary artery vasoconstriction. And thereby there will be increase in the pulmonary artery pressure that will result in pulmonary hypertension. And because of this pulmonary hypertension, the individual will land up in cor pulmonale. Right? The individual will land up in cor pulmonale. Okay, so these are the findings that you will see in patients with the asbestosis. Okay, now like if you see the asbestosis, this is one of the occupational lung disorder. So definitely what will be the treatment? Avoidance of the exposure. That is one of the very, very important point. Avoidance of the exposure. Like the same thing, the individual with asbestos exposure, again, if the individual starts smoking, then he will develop bronchogenic carcinoma. Right? He will develop bronchogenic carcinoma. So that was the story about the asbestosis. Right? Asbestosis, an occupational lung disease. What all manifestations can be seen in the lung? Pleural effusion can be seen. Plaques can be seen. Malignant mesothelioma also can be seen. But what is the most common? The most common is the development of the pleural plaques. Okay? Right. Now we will move on to the next question. Yeah, yes, Monica Mauni. Asbestosis, it can lead to adenocarcinoma. It can lead to adenocarcinoma. Okay. Right. So this is another next very interesting question. And let me see how many of you can answer this. This patient presents with skin lesions. These are the skin lesions. Okay, these are the skin lesions. So presence with skin lesions shown and with persistent hyperglycemia. This point is very, very important for me. Persistent hyperglycemia. Right? And additional features of this syndrome include all of the following except. That means the question asked is which is the false statement. The question asked is which is the false statement. Fever, glossitis, anemia, diarrhea, weight loss. Good. Yes, Shabnam Khan, can you tell me what is the diagnosis in this patient? What is the diagnosis in this patient? Why did you answer A? Why did you answer A? I'm waiting for the diagnosis. If anyone can tell the diagnosis, I'll be very happy. So whoever has answered A, please tell me the diagnosis. So diagnosis in this clinical scenario, 99999. Plummer-Wilson syndrome, how it can be, Gopalakrishnan? Plummer-Wilson syndrome, the individual should have iron deficiency anemia, right? There will be esophageal involvement will be there. So is that there in your history? Not there. Right. So this is Glucagonoma syndrome, right? Glucagonoma syndrome with necrolytic migratory erythema. Sir, why are you telling glucagonoma? Why am I telling glucagonoma is, what is there in the history? In the history, there is persistent hyperglycemia. Right, in the history it is mentioned that there is persistent hyperglycemia, and along with that there is skin lesions, and that is suggestive of glucagonoma. Now, what are the other manifestations? This glucagonoma, remember, this particular syndrome as such, it is very rare, and it occurs in the age group around 40 to 60 years. Right? And how will you diagnose this glucagonoma? The diagnosis, remember, it is made with serum glucagon test. Right? It is made with the help of the serum glucagon test. So serum glucagon levels will be increased. And remember, in almost 70% of patients, right, 70% of patients, they have necrolytic migratory erythema in case of glucagonoma. In case of glucagonoma, 70%. Now in glucagonoma, what are the other features now? What are the other features? The other features include, there will be presence of glossitis. and they will have normocytic normochromic anemia. They will have diarrhea and they will also have the weight loss. And apart from, but they will not have any fever. In case of glucagonoma induced necrolysis, they will not have fever. The other features are that they can have angular cheilitis. They will have angular cheilitis. Okay, they will also have decrease in the amino acid levels. There is a decrease in the amino acid levels. Now, why there will be decrease in the amino acid levels? Very good. Shabnam Khan has answered hypoaminoacidemia. Why is that? Why? Because the glucagon, it will, right? Glucagon, it will increase the amino acid destruction. It will increase the amino acid degradation, and that is the reason why there will be hypoaminoacidemia in these individuals. Now, the associations, this glucagonoma, it is associated with the other tumors as well. What are the other tumors? They include pancreatic duct and as well as islet cell tumors of the pancreas. And in 20% of cases, it is also, glucagonoma is also associated with the MEN1. Glucagonoma is also associated with the MEN1. Okay. Now, what is the treatment? What is the treatment for this particular, the glucagonoma? See, management in the setting of the glucagonoma, it includes the resection of the tumor. So it is a tumor which is originating from the alpha cells of the pancreas. Right, alpha cells of the pancreas. So what is the treatment? You need to do the resection of the tumor. Right, you need to do the resection of the tumor. So that is the ideal treatment for these patients with the glucagonoma. Right, and apart from that, the somatostatin administration has to be done. Somatostatin analogs. Right, and because there is hypoaminoacidemia, so what you should do? You should give intravenous amino acid infusion. Right, intravenous amino acid infusion should be done. Okay, so that is about your glucagonoma. There is also another terminology called pseudoglucagonoma. Pseudoglucagonoma syndrome, it occurs in cirrhosis of liver, Crohn's disease, celiac flu, and malabsorption syndromes. Okay, so that is about the story of your glucagonoma. Okay, now you take the next important image and clinical based questions. So until now, can I just have some feedback? How do you feel the questions are? Yes, just please tell me how are the questions. Okay. Good, very good. So thank you very much for your feedback. Now, let me just read this question for you. A 60-year-old woman presents with arthritis and a long history of recurrent painful ulcers. Long history of recurrent painful ulcers. Now, where are the ulcers present? Yes, Gayaz Mohammed. These are, you're feeling too difficult, but let me tell you, these are the questions that will appear in your exams. I don't know whether you have written August 31st exam or not. For all the FMGE students, August 31st was really a nightmare. Was really a nightmare, right? I feel very pity about that. So you have to be prepared with these type of difficult questions. Then only you can answer your, you can attempt your exam comfortably or in the month of December. Okay. Right. So a 60-year-old man presents with arthritis and long history of recurrent painful ulcers over the mouth and as well as the genitalia. Past medical history is notable for venous thromboembolism and uveitis. What is the diagnosis? What is the diagnosis? primary syphilis, herpes simplex, sarcoidosis, Bicep syndrome, niacin deficiency. Right, great. Great. Everyone is answering. Okay, so who has answered first? Shravan Kumar. So Shravan Kumar has answered first and then followed by that Sai Taruni Danda. Excellent. So the diagnosis in this patient is, the diagnosis in this particular patient is the Bicep syndrome. Okay, that is a diagnosis. Now, why is it Bicep syndrome? So can anyone tell me what is the other name of this biceps? What is the other name of this biceps? Who will tell me this? Now remember, in biceps, the oral cavity is involved, right? Oral cavity is involved, okay? And the genital, right? This is the involvement of the vagina. And remember, there is also involvement of the eyes. Involvement of the eyes will be in the form of anterior and as well as the posterior uveitis. So that is the reason why the other name of this particular syndrome, Bicep syndrome, is oro-oculogenital syndrome. Right? Oro-oculogenital syndrome. And yes, very good, Sai Tarni. The other name of this, it is also called, okay, right. So this is the other name of this particular disease, that is oro-oculogenital syndrome. Okay, now we will move on to the discussion of this biceps in short. In biceps, can anyone tell me what is the HLA association in biceps? What is the HLA association in biceps? Please tell me what is the HLA association in the Bicep syndrome? So, if you take the HLA association in the Bicep syndrome, very good. So that is your HLA B51, right? HLA B51. Right? It is not HLA B27. HLA B27, Shabnam Khan, you are answering all the questions correctly, but why are you telling it is HLA B27 for the biceps? It is completely incorrect. So HLA B27, just now I have said you, it is seen in case of psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and recurrent or reactive arthritis. But in case of biceps, you have HLA B51 and as well as HLA B5. Right, HLA B5, okay, right. So very good. Chandia has answered both. Okay, only Chandia has answered. No one, everyone was answering only HLA B51. So Chandia, very good. So it is both B5 and as well as B51. Okay, right. So now what is the treatment for biceps? What is the treatment for biceps? Yes, Shabnam Khan, you should be very careful by mistake. Okay, so everyone should be aware of this SMS syndrome. What is this SMS syndrome? This is called silly mistake syndrome. And those students with SMS syndrome, they suffer a lot. There is no treatment for this. Okay, so please be careful, Shabnam Khan. Right, so it is not any disease, so please don't worry. Right, so what is the treatment for the biceps? Okay, so the biceps, the treatment is corticosteroids. Right, corticosteroids. Okay, and other immunosuppressive therapy can also be given. Other immunosuppressive therapy can be given. Okay, right. Now, followed by this particular biceps, now we will move on to the next important, very, very important question. Yes, we have a 42-year-old woman. with a past history of multiple sexually transmitted diseases and progressive dementia has the skin lesions shown here and shortness of breath. Of the procedures listed below, which one is the most important for directing definitive therapy for unifying the diagnosis? Listen to read the question properly. What is given? Of the procedures listed below, which one is the most important for directing definitive therapy for unifying the diagnosis? What does the patient has? The patient has the progressive dementia, right? And the patient has the skin lesions, and the patient has the shortness of breath. Abhi bolo. What is the diagnosis first of all, and what is that you want to do? What is that you want to do? Oh, very good. So Pravalika. So Pravalika has answered. Very good, Pravalika. Yes, Pravalika. What is the diagnosis? Yes, Pravalika. What is the diagnosis in this patient? Right, Shravan Kumar answered. Shabnam Khan answered. Diagnosis bolna. It is not necrotizing fasciitis. It is not necrotizing. See, the woman is having multiple sexually transmitted diseases. Based on that, you tell me. Based on that history, you tell me what is the diagnosis. See, unless you don't tell the diagnosis, then the discussion becomes very difficult. Some of you are answering. Yes, Shabnam Khan has answered it. Very good, Shabnam Khan. So this is the tertiary syphilis. Right, so this is your tertiary syphilis. Okay. Right. So now what is that lesions which are present over the skin? What is the chest X-ray given to you? What is that? All we will discuss now. So the diagnosis is tertiary syphilis. Now you see the skin lesions. The skin lesions which are given to you, they are gummatous osteomyelitis. Right, it is your gummatous osteomyelitis. Okay, then you take the chest X-ray, whatever is given. So in syphilis, what will be the effect over the aorta? The effect over the aorta in syphilis is that they will develop what is called aortitis. Right, they will develop what is called aortitis. And secondary to this aortitis, these individuals, they can have ascending aorta aneurysm, right? They can have ascending aorta aneurysm, and they can also develop what is called aortic regurgitation. That is what is the syphilitic manifestations over the aorta, and you can see that. So this is the aneurysm which is there in the individual. This is the aneurysm. Okay, now along with that, the patient is also having progressive dementia. That means what? There is involvement of the CNS also. That means there is neurosyphilis. Right, neurosyphilis. So neurosyphilis, where do you see? You will see neurosyphilis in tertiary stage. And that particular neurosyphilis is nothing but tabes dorsalis. Right, tabes dorsalis. Now, what is the question asked to you? The question asked to you is which one is the most important for directing definitive therapy for making the diagnosis? What is the best diagnosis? The question is being asked. So remember, obviously in case of syphilis, you need to do the antibody testing. What is that antibody testing? That is FTA. That is fluorescent treponemal antibody absorption test. right? FDA absorption test, fluorescent treponemal antibody absorption test. So if this particular FDA antibody test is positive, then what is the next best investigation to confirm the tertiary syphilis? The next best investigation to confirm the tertiary syphilis is CSF analysis, right? CSF analysis. And for the CSF analysis, you need to do the lumbar puncture. You need to do the lumbar puncture. Okay. So lumbar puncture is the best investigation that you need to do in these individuals. Now, for example, now you see the treatment. Can anyone tell me what is the drug of choice for tertiary syphilis? What is the drug of choice for the tertiary syphilis? Anyone? So tertiary syphilis or the neurosyphilis, the drug of choice is penicillin G. So this penicillin G, this has to be given for at a dosage of 12 to 24 million units. Right, 12 to 24 million units has to be given. Right, and for how many days you have to give? 10 to 14 days you have to give. Right, 10 to 14 days you have to give. Okay, so that is about your tertiary syphilis. Right, now what we will do, we will take just one question and then stop the discussion. We will take just only one question and then stop the discussion of this particular session now. Okay, right. So I will wind up the session with an easy question, right? So that everyone should be happy at the end of the day that you have answered the question. Chalo, bolo. So we have a 52-year-old woman, right? We have a 52-year-old woman who has diarrhea, wheezing, and the flushing reactions shown here, which seem to be associated with emotion and alcohol ingestion. What is the best screening test in this patient? Urinary metanephrines, anti-mitochondrial antibodies, anti-nuclear antibodies, skin biopsy, 5-hydroxy-indole acetic acid. So what is the diagnosis? Diarrhea is there, wheezing is there, facial flushing is there. You see this, face is completely flushed. Diagnosis bolo. What is the diagnosis? Right, very good, very good. So Sai Taruni Danda, Sai Taruni, very good. So carcinoid syndrome. Carcinoid syndrome. So that is the diagnosis in this patient. So in case of carcinoid syndrome, what will be the best screening test? The best screening test is 5-hydroxy-indole acetic acid. The best screening test is 5-hydroxy-indole acetic acid. Okay. Now you take the urinary metanephrines. Where do we do this? In pheochromocytoma. And you take this anti-mitochondrial antibodies. Where do you do this anti-mitochondrial antibodies? We do this in case of autoimmune hepatitis. There are no features suggestive of autoimmune hepatitis in this patient. Anti-nuclear antibodies, where will you do? Systemic lupus erythematosus. 5-hydroxy-indole acetic acid, where is the screening test you will do? Carcinoid syndrome. So remember now, all that clinical manifestation, whatever is given to you, that is diarrhea, wheezing, flushing reactions, all that they point towards your carcinoid syndrome. All that they point towards your carcinoid syndrome. Okay. Now, and in the same patient, you see which one of the following likely will be most effective for decreasing the symptoms of the individual. Beta adrenergic blockade, psychiatric consultation, bulk fiber supplementation, somatostatin analogs, systemic steroids. What is that you want to give? So diagnosis is what? Carcinoid syndrome. Right? Diagnosis is what? Carcinoid syndrome. So in carcinoid syndrome, what will you give? Somatostatin analogs, that is octreotide. Somatostatin analogs, that is octreotide. Okay, so the treatment in these patients with the carcinoid syndrome is the somatostatin analogs. Somatostatin analogs. Okay, so with this, I will just wind up the today's session. With this, I'll just wind up the today's session. Right? I hope everyone has taken the advantage of this session, because these are free sessions. Please inform to your friends also. Let everyone take the advantage of this session. And every day you are having this clinical based. So tomorrow again, you will have the session at 7 p.m. Tomorrow also you will be having the same session at 7 p.m. And let me tell you, please don't lose confidence at any moment of your preparation. So you have to be very self-confident that you will definitely clear. Right? So definitely I do understand that the 3 months are very short for you for your preparation, but we have to go along with the wind, right? We have to cope up ourselves, right? We have to fasten our shoe to see that we have to increase our speed of reading also. Okay, so at any moment of time, please don't get depressed. Okay, this time your attitude should be, I will clear the exam definitely. So be self-confident, believe in yourself, right? Believe in yourself. Don't believe in other impression on you. Your parents might be having some impression. Your friends might be having some impression on you. Don't believe on that. Believe in yourself that you can definitely clear the exam in this month of December. So with that hope and attitude, just start preparing, and revision is very, very important. Let me tell you, even though you are reading the entire content, don't end your day without revision. Don't end your day without revision. Okay. So yes, Gayaz Mohammed, exit exam, yes, it looks like it has been approved, but this December exam will be there. This December exam will definitely be there. Okay. So I wish all the best for all of you. So please read well, right? And don't get depressed, and be confident yourself and believe in yourself. This time you will definitely clear the exam. Right? So thank you very much. See you in the upcoming sessions. So tomorrow, 7 p.m. sharp, we will discuss the similar type of image-based and clinical-based questions. Okay. Yes. Siva Maruti, yeah. I will send the PDF to the Arise Medical Academy staff. I was a little busy, so I couldn't send, but definitely by night I will send to the Arise Medical Academy staff, and you can collect these particular MCQs with them. These all will be very helpful for you in the final revision. Yeah, Adarsh Soni, I will do that. I will send in the Telegram group, or I will just send it in the to the Arise Medical Academy staff. Okay. So thank you very much, and see you in the upcoming sessions. That is 7 p.m. tomorrow.